starting with a diagnosis. So this is Rundle's curve, which holds good for any autoimmune disease. There's activity and severity. Activity denotes the function of inflammation and severity denotes the functional or the cosmetic deficit. And the aim of any modality of treatment would be to blunt the peak of the activity curve and also to shorten the duration of the activity and the severity curves. So then to know the activity, we have the widely accepted clinical activity score, which was published by Moritz et al. In 1989, which has 4 parameters. On the first visit, we assess pain, redness and swelling on a total score of 7, and a score of more than 3 by 7 would denote active disease. And at subsequent follow-up visits, we also assess the loss of function. So a total score of 10, wherein a score of more than 4 by 10 denotes active disease. Then we have the UGOGO severity score, which has 3 gradings: side-threatening, moderate to severe and mild disease. So the disadvantages of UGOGO is that, for example, proptosis is there in all the 3 parameters, and it doesn't take into consideration the patient's perspective. It is more of an objective scoring. So to overcome this, Dolman et al. Published this VISA scoring, which is both subjective and objective, and it also denotes disease progression. It is more comprehensive, but in our clinical practice, it might be a little time consuming. So as I've emphasized that thyroid eye disease is a disease mainly of clinical diagnosis. However, imaging would be necessary mainly in euthyroid ophthalmopathy and also in unilateral asymmetric proptosis, and also in vision-threatening disease and before decompression. When you are suspecting any cerebral pathology such as CST or CCF, then brain imaging would be necessary. CT is the preferred modality, wherein fat serves as an excellent contrast material. MRI with diffusion-weighted imaging and T2 hyperintensity and prolonged T2 relaxation time helps in denoting the activity of the disease in previously treated disease, and also absolute diffusion coefficient mapping is also useful to denote the activity of the disease. Nowadays, OCT angiography in TED is gaining momentum. So now you know the activity and severity. So now it becomes pertinent to know when to treat the disease. So logically, side-threatening disease would require urgent treatment. However, mild disease would require optional treatment. Then now that we know when to treat, how to treat becomes this one. So the 2021 UGOGO clinical practice guidelines has given clear-cut guidelines as how to manage the mild disease. In mild disease, it is mainly supportive treatment in the form of artificial tears and also selenium supplementation. Sorry, excuse me. So in moderate to severe disease and active Graves ophthalmopathy, the first line of treatment would be intravenous methylprednisolone and along with mycophenolate mofetil. The intravenous methylprednisolone can be started in the dose of 500 mg pulse therapy or 750 mg pulse therapy, and once the disease goes into inactive phase, then rehabilitative surgery as needed would be required. And the second line of treatment would be cyclosporin or azathioprine, orbital radiopathy, teprotumab, rituximab and tocilizumab. And in side-threatening disease, usually you start with a high dose of intravenous methylprednisolone therapy, and finally, if it is not responsive, then urgent orbital decompression would be indicated. So now medical management. So these are the target therapies. Glucocorticoids usually act on both T cells and B cells. So oral versus intravenous, it is proven beyond doubt that intravenous is more efficient with less side effects. Kali's regimen has been widely practiced with a cumulative dose, safe dose of 4.5 to 8 grams, started in the pulse of 500 mg weekly for 6 weeks, followed by 250 mg weekly or 750 mg weekly, followed by 500 mg for 6 weeks, with the introduction of an immunomodulator at pulse 4. Then steroid sparing agents would be either cyclosporin, mycophenolate or azathioprine. So mycophenolate inhibits both T lymphocytes and B lymphocytes, given in a dose of 1 gram per day for 24 weeks, which has a minimal long-term benefit and it is well tolerated. Then cyclosporin alone or in combination with glucocorticoid therapy, given in a dose of 5 mg per kg body weight. It inhibits calcineurin and also prevents the secretion of IL-2 by CD4 plus lymphocytes. And azathioprine, which is usually practiced given by the oculoplasty surgeons alone, which inhibits DNA synthesis, which has a good adverse effect profile, and also it decreases morbidity, reduces the clinical activity score, and also improves diplopia. Then orbital radiation therapy, it is the most controversial I feel. It reduces the secretion of pro-inflammatory cytokines from activated lymphocytes. So this was one patient who presented like this, who was given pulse methylprednisolone therapy along with mycophenolate mofetil. There was remission, but he relapsed later. He was not ready for any surgical treatment. So orbital radiotherapy was given, and this was the final outcome. And coming to the surgical management, we all have been taught that orbit followed by extraocular muscles and eyelid, but it is now proven that combined orbital decompression and aesthetic eyelid surgeries has better patient satisfaction and reduced number of surgeries. And for eyelid surgery, it's LPS recession in the quiescent phase, whereas in the active phase, non-surgical modalities in the form of botulinum toxin, triamcinolone, and hyaluronic acid fillers can be used. This is one of the patients wherein combined orbital decompression and aesthetic eyelid surgery was done in the same setting. Targeted therapy includes teprotumab, which is readily available in the West, not available in this subcontinent, rituximab, tocilizumab, and infliximab. Rituximab is against CD20, 2 infusions of 1 gram 2 weeks apart. So this was one such patient who had all the high-risk factors, secondary glaucoma, active vision-threatening disease with DAWN, who was given IVMP pulse therapy, which was supplemented with rituximab, and this is the final outcome. Teprotumab, which is gaining momentum, it acts against IGF-1 receptor. It reduces hyaluron production and cytokine stimulation. The quality of life was significantly improved with significant improvement in diplopia, and long-term benefits even after the final infusion was the most advantageous this one, and the others are tocilizumab, adalimumab, and infliximab. So in conclusion, thyroid eye disease is a progressive debilitating autoimmune disease with a very limited window period to treat, which requires meticulous examination because clinical diagnosis is the cornerstone in the diagnosis. A multidisciplinary team approach is required, and novel targeted therapies are the way forward. Thank you very much for your kind patience.
I just explain few points regarding euthyroid ophthalmopathy is one of the burning issue right now. Most of the time there may be started with a hypo, U and hyper, and that time the general physician or even the endocrinologist also misguide the people because it's not possible to all do these drugs. There may be some issues if there is some complication because there is systemic complication is very high. So we need some support from the other stuff.
Yes, sir.
And there is a theoretically is very easy, but practically there is some issues. How you will tackle all those points? Suppose euthyroid normal, TTTS normal, even anti-TPO are normal, then in such cases clinically is clean cut case of a thyroid ophthalmopathy.
Yes, sir.
What
So
will be your approach?
usually euthyroid ophthalmopathy, we all were thought that it was more of a clinical diagnosis, but now with the present studies, it is proven that only TSH receptor antibody being positive or proptosis alone doesn't necessitate the diagnosis. We require imaging to support the diagnosis, especially in the form of extraocular muscle involvement or orbital apex crowding and all. So supplemental diagnostic modalities in the form of visual fields and to how much extent the optic nerve is also affected we'll have to take a holistic approach to treat such diseases. And also there is a lot of controversy among the endocrinologists itself whether to initiate thyroid medications in case of euthyroid ophthalmopathy. Because many a times as an oculoplasty surgeon we see that the burden of disease is so much, the quality of life is so much compromised and the patient is so much in trouble, but then for them they just rely only upon the free T3, T4 and the TSH levels. Yes. If the TSH levels are normal, they don't even budge even after personal communication with them. But then I don't have much data, but in my practice when thyroid medication was started even in euthyroid ophthalmopathy, there was better improvement in symptoms, and whatever treatment we initiated like oral corticosteroid, the effect was better when it was supplemented with thyroid control also.
Thank you.
Thank you.
In my practice generally if clinically is a tau, thyroid
Yes, sir.
associated ophthalmopathy. So I straight away advise anti-TPO and thyroid antiglobulin
Yes,
first.
sir.
Because that if the TSS or free TT4 is within the range, there is a patients are generally reluctant. They will not go for that is aggressive one, and perimetry in the first one.
Yes.
So that initially in our hand, initially first all I this is it to motivate people.
Yes,
That's
sir.
a one thing we have to, because more than 60% of they are basically 1 or 2 years senior. To convince them it is very difficult in higher post also in some hospital.
Definitely.
So very very big issues. Yes.
Yes.
Practically, are we having all those rituximab and all?
Yes, sir. Rituximab is available, and immunologists are quite keen on, on administering rituximab.
So you take help of other
Yes, sir.
specialists?
Definitely. With in consultation with the immunologist, and the immunologist will only follow their other biochemical parameters so that the adverse effect profile is also in check.
Only few, the serum creatinine and then liver function test we can also, because
Yes, sir.
especially I am personally using the azathioprine up to that in some uveitis patients. With this, if the all parameters are normal, then we can start safely, because if you send to them you can discuss, but if you are sending to some senior one, technically it will be little difficult to convince them. So generally I send to some senior with a note, and there is just technically that I take a consent from that proper authority, like, and then start.
Even I start myself on Azuran, and I check the liver function test and CBC periodically every 4 to 6 weeks. And if there's any, even the slightest discrepancy, take the immunologist helps.
Even they are also doing the same thing. Whatever we can do, they are also doing the same thing. So that is, we should maintain the proper protocol, and for the CPA point of view for protection, we can send to someone what one consent. That's enough.